EIIC Innovation and Improvement Center, which are supported in part by the Health Resources and Services Administration of the United States Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of or an endorsement by HRSA, HHS, or the U.S. government. And something just happened to my screen, so am I still sharing?
Go ahead and reshare for me, Julie.
Okay. Is that okay? So our session objectives today, we were going to explore pediatric readiness recognition programs and look at establishing meaningful criteria. We're going to discuss the minimum criteria for ED pediatric readiness programs, and then we're going to prepare for completion of round 2 voting on the Delphi process. And then we're also going to discuss the minimum criteria for pre-hospital pediatric readiness programs and vote whether what should be considered in round 2. So as a reminder, the goal of the PRRPC is to work with all the participating states and territories to develop recognition programs, incorporate key recognition criteria to align with the performance measures, and then also to support the expansion of recognition programs. So at this point, I'm going to hand it over to Kate Remick, and we're going to talk a little bit more about the Delphi process.
Great. Thank you, Julie. I know this has created a lot of discussion and a lot of confusion, this whole process. And I just want to relay that this is not the only part of the work that we're doing collaboratively. There will be future work related to how do we think about applications and criteria and develop process maps? And we know that everybody is at a different place and point in time. But the goal of this Delphi process is really just for the EMSC state partnership managers as a group to come to some kind of consensus around what should be the bare minimum criteria for the most remote, low-resource institution in your state or territory. We're not trying to slow down anybody in the process. Many of you already have very robust pediatric recognition programs, either for EDs or EMS. We're not telling you to stop them. We don't want you to. We're not telling you to hold on your process of developing your own internal criteria or gathering support or moving forward with recognizing hospitals or EMS agencies. All we're trying to do is try to say, as a collective group, can we agree upon a bare minimum criteria that is meaningful to be recognized as PEDS ready? And part of this stems from the fact that many programs were developed, 10 plus years ago. Some are relatively new, and yet there are still many states and territories that don't yet have programs in place and are trying to figure out, where do I start? What criteria do I use? And this is really an opportunity for us to kind of come together in open discussion, to come to agreement about what is meaningful. And it's really only been in the last few years that we've had any data to help inform us of this process. We tried to do this in 2014 during the Facility Recognition Collaborative when that first kicked off, and there were 14 states involved. And each of those states came together and said, what should be the minimum criteria that we use? And unfortunately, at that time, it was not easy because we didn't have a lot of data to suggest what are the components that actually lead to improved outcomes or improved readiness overall. So a lot of the discussion was centered more around feasibility and what people thought might lead to improved readiness. But now we have information, evidence that can help to support us in this work. And I think because that evidence exists, we have a responsibility as a program leading these recognition initiatives to ensure that our criteria are in some way meaningful. And I think even establishing the most common bare minimum thread is a starting point to getting us there. What I also wanted to share is a little bit more about this Delphi process. So the criteria that have been presented for ED and that will be presented today for EMS are criteria that currently exist in one or more programs or that are clearly highlighted in the policy statement. The recommendation is that from this group is that all of those be considered to move forward for scoring by your larger team and committee. If there's any question as to whether you aren't sure if a criteria should or shouldn't be included, go ahead and push it forward, because there are going to be lots of opportunities coming for people to rank those criteria, score them according to feasibility, evidence, and importance and impacting overall readiness. So this first step is just sharing with you what the current landscape looks like, what the current criteria are that are being used. And as you move into this next round, each of you will have an opportunity to work with your teams, your committees, your advisory councils to say, is this something that we feel is feasible in our state? Do we feel that there is evidence that we can back this criteria in our state and or territory? And do we feel that it'll be important in promoting overall pediatric readiness? So what the point where we are at with the ED recognition criteria is now at the round 2 ranking. And I'll share some of the results that happened from round 1. But with respect to the EMS, where we are is really at that green circle, which is, do we think these criteria should be put into the process? And that's really all we're voting on today. This is not a final vote. There will be more opportunities to score, rank, and choose. And I will add one more piece around this, which is that we really want this to be the voice of state partnership managers, and we want there to be equity in that. So even though as a state partnership manager, you might have an advisory council that you want to go to and get their feedback, some state advisory councils may be larger than others. And we want to ensure that there's equity across the state partnership managers. So while Casey has shared the ranking with all of you to go through, and you're welcome to share that with your team, what will happen is that there will be one essentially score ranking attributed to every EMSC state partnership manager who is participating in this work. And as of now, we have 51 states or territories represented. So that is, I feel, a fairly reflective voice of all of you, is that we have 51 of 58 participating in this work. It may be as well that as we move through this process, we get to round 2, there's lots of open discussion on the different criteria, not a lot of agreement. We go through round 3, we look at it again, still not a lot of agreement. There could be a round 4 or 5, but we're really trying to push this process forward so that states that are just working on developing their programs might be able to use this criteria to help influence the adoption in their state. I also want to reiterate that these criteria are not intended as the standard that everybody needs to adopt. They are intended to be a very bare minimum, the least common denominator that we could use across all states or territories. So if your state is requiring much more, all the more power to you. And we are not trying to limit that. So I just want to pause before I jump into any of kind of the results from round 1. Actually, if you can go to one more slide, Julie, that would be great. Just on kind of the objectives and the benefits. And I just want to see if there's any comments, questions, or concerns, because I know there's been a lot of discussions around this. Please speak now if you have big concerns.
Dr. Remick, it's Dwayne. I'll just say, I'm one of those people that had concerns, and we've had the conversation, and I think, after wrapping my head around it, it becomes kind of a baseline for what we're doing, and we're anxious to see what everyone's baseline minimum standard opinion is to help support decisions we're making at our program and our committee level. It almost, in a sense, either validates it or supports it, so that it's not arbitrary on our end, because we're not working off of some science. We're working off of opinion, experience, and things like that. So I wanted to take it and flip it around to be positive towards our effort in developing a program, or with the pre-hospital effort, reviewing the program that our state's had for 10 years now to make it better.
Thanks, Dwayne, for sharing that. I appreciate that. Okay. Well, I'm going to take silence as moving forward with a overview of what happened over this first round. Can we move to the next slide, Julie? So for the ED, most of today is going to focus on the EMS side, as you, I think, are all aware, but I just want to review what happened with the ED and kind of the time frame we're looking at. So right now, the round 2 criteria are out for all of you to discuss, rank, review with your committees. That is all happening offline. And our hope is that we will be able to come back together at the December session and be able to really discuss how it looks, what the results are. It'll be an opportunity for people to make comments about verbiage. It's an opportunity for people to champion any particular criteria that they feel absolutely should or should not be included. And if there are, criteria that you feel got pushed out and shouldn't have been, and it's an opportunity for you to try to advocate for them being added back. Based on that discussion and the consensus that's achieved during that call, so it's really important that all the people that you need on that call are on that call for December, and you come ready to have that discussion. Then offline after that will be an opportunity for everyone to re-rank, rescore, and then hopefully come January, we'll be able to review that round 3 results and make any minor adjustments or nuances to those considerations, and hopefully we'll have consensus. So that's kind of the timeline we're working with. Ideally, like I said, it's possible that at the round 3, we're not quite there. And if that's true, then we'll push forward, but it at least gets us closer. Next slide, please. This is the timeline for the pre-hospital one. So that first graphic is a typo, but it's established EMS recognition programs, so minimum criteria. Those will be discussed today during the November session. Opportunity to really get your head wrapped around what they are, what are the pros and cons of, potentially moving them forward into round 2. And everybody will get to have a say, do we think it should be included in our decisions or not? Again, I just want to emphasize, if you're unsure, there's no harm in saying, yes, move forward. If you are absolutely opposed to it, then obviously vote no. Anything that gets at least 50% votes will make it into round 2 for further discussion. And then hopefully we'll be able to review those results in December and hopefully get to round 3 in January as well. So these next 2 months will be really important in terms of getting there. Next slide, please. So just to review what happened with the minimum criteria, next slide. So these were the criteria that are currently adopted in a variety of programs across the US for ED recognition. You can see on the right-hand side, the percent programs, of those programs that had this criteria included in their recognition criteria. So 95% of current ED recognition programs require at least one PEC. 23% of current pediatric recognition programs require a minimum pediatric readiness score. So, and you can see everything in between. So those were the criteria that were presented and discussed, with slight variation and nuances to the language that will continue to be open for discussion. Next slide, please. And again, the goal is, if we say 50% yes, then it moves into, this scoring process of evidence, feasibility, importance, and will get us there. So if you have any concern or doubt, not sure, go ahead and vote yes, and the criteria will move forward. If you are opposed to it, it won't. So these were the results from the round one. So these are now criteria that were input into the round two consideration for everybody to take back and begin to really think about in much greater depth and rank them essentially according to evidence, feasibility, and importance for readiness. And anything that scored over 50% in that round one was included. And you can see how each of these was rated by your peers. So 98% of people on the call and who completed the survey offline said, we feel at least one PEC is something that should be considered. You can see the lowest number that was considered or included was interfacility transfer agreements at 58%. So those were all included in the next round, and you should have received those. Next slide, please. The only two items that were not pushed forward, and this does not mean that you cannot use them. 100%, these are within the policy statement, absolutely recommended there. And if you want this to be part of your minimum criteria in your state or territory, you're welcome to do so. But based on the consensus from the group felt that having both a nurse and physician PEC perhaps is not feasible for the lowest criteria, and that having a minimum score of 88 or above should not be part of the minimum criteria to participate. And I think the reason for that, if you all recall that discussion, was people didn't want to prevent EDs from having a weigh-in, and didn't want to set the bar so high that sites just didn't even choose to apply. So I think that's why these were not included. But one last time, if you want them in your program, no one's preventing you. All we're trying to get to consensus on is bare minimum for the lowest resource institution. So if you have 3 tiers, it would be lowest tier. If you have 1 tier, we're trying to look at that. Any comments? Okay. So next slide is with round 2, what you'll see is each of these criteria are listed out, and you are asked to provide a score for each one of those criteria on 3 different areas of focus. First is based on what you know, and based on hopefully what we know, because we reviewed some of this, do you feel like there is a significant amount of evidence that this particular criteria is associated with better outcomes for children and adolescents? The second is, do you believe that this criteria is feasible for the lowest resource institution to implement? And the third is, how do you feel about this criteria related to improving overall pediatric readiness? So those are 3 different kind of pieces, and every single criteria that was listed on the prior page will get, a score of 1 through 5 on each of these, and those will be shared moving forward, and it will lead to a ranking where you all will see, my peers felt this particular criteria was the most important and this criteria the least important, and it'll allow us to get closer to consensus on it. Any questions about that? Okay. Next slide. And I think I'm ready to turn it over to Kathleen. She's on.
Yikes.
Yay.
Okay, I'm here. Okay. Thank you guys. And so again, just to reiterate a lot of what Dr. Remick said, we are going through for the very first time some concepts on pediatric pre-hospital recognition readiness. And part of the where these items come from, we do have some information on evidence, a rationale behind it. We also some of these criteria also come from the checklist and the planned assessment. One thing for us all to think about as well, everybody here is funded by EMS for Children, and one of the aims was that all of these state partnership programs would work on some form of EMS readiness recognition program in their state. And yet we're doing that before we have a national assessment and even know what our agencies are scoring. So that being said, again, I think that, this is our best efforts to kind of collectively come together with what we already know and use some of the information to move forward. So with that, next slide. So here, Nick, you have to, thanks. So here we're going to discuss some core criteria for consideration of, again, that lowest and/or potential single tier program. Whether agencies want to, or whether states want to have several tiers for their pre-hospital pediatric readiness recognition program or not. It's up to the state. The criteria should be considered as a minimum criteria, voting yes or no. If greater than 50% yes, we would have it be considered in round 2, where it could be ranked based on evidence, feasibility, importance, just as Kate was discussing. And our goal is to aim for 3 rounds of voting and scoring before we achieve consensus on this. Next slide. So here, similarly to the prior slide in blue, this is the environmental scan of the existing pre-hospital recognition programs. There's a total of 9 that have been identified through HRSA. And you can see the bar graph to the left, even though the font is a little small, and then the percentages on the right of the slide. Given the fact that a PEC is kind of a performance measure that all states are being surveyed on every year, looking at how states have started to arrange their criteria, 100% of the states require having a designated PEC. 100% of the states require a process for pediatric specific education. And again, these 2 things align with the existing performance measures. About 80% require that the providers physically demonstrate the correct use of equipment. 80%, around 80% also require pediatric specific policies, procedures, and protocols. 67% of the states of the 9 require that the agency utilize the national consensus guidelines for their equipment. Now, some states may choose not to have this as part of their program, mainly because, licensure of ambulances or agencies may happen at the state or county level with an existing standard. And so, there are different reasons why this might or might not work for your state. And then you can see it trickle down. Very few require that EMS agencies have a disaster plan. And I think that is something that we'll have to think hard about as we move into looking at these minimum criteria, along the lines of thinking about why having a disaster plan and what EMS agencies should be doing in this regard. I think we just need to kind of be mindful about that as we move forward. Next slide. So include at the minimum the following elements in the highest tier. Again, this, is these are the three things that the overall performance measures that we are all going to be answering to with regards to our states in performance measure assessments. Having a PEC, a disaster plan, and skills checks, these are all just basic things. And so we have some questions specifically around this, around pediatric readiness recognition that people will be thinking about as we ask about these criteria. Next slide. So any questions about that before we go into the specifics? Or chats, or hands raised, or tell me to get off the mic. Somebody else can take over. Anyone? You all there still? Dwayne, are you there?
We are here.
Okay.
Please keep going.
All right. Okay, just checking. Thank you. All right. Having a PEC. Why is this important? And you can advance the slides for the animation. So pediatric emergency care coordinators, are kind of what we feel are the backbone of pediatric readiness for emergency medical services, outlined in the Emergency Care for Children Growing Pains IOM report, also outlined in the other IOM report, EMS at the Crossroads, a resource document by myself, Tony Gross on this call, and Kate Remick, outlining the importance of this as well, and being published by the National Association of EMS Physicians. And also, again, an item that is getting annually measured. Many things to be PEDS ready at the hospital level, we know really rely heavily on the PEC. And when we extend that to the out-of-hospital environment, you can see all of the things that the PECs say they do and why they're important in leadership within EMS. So next slide. So criteria number 1, yes or no, should the agency have a designated PEC? This is your opportunity to kind of vote in on this one.
And have discussion if people have questions about any.
Yeah.
Free to chime in if there's comments.
Is this a barrier? Is this a challenge? Is this something everyone has already been working on? Any thoughts or concerns from the group?
Kathleen, quick question.
Yeah.
Do you specify whether this is going to be a full-time person for the agency, part-time? Is there any parameters that you want to assign to this, or?
That's a great question, Mike. I would posit it to the rest of the group about their thoughts on this, and have people weigh in. I think that we've seen models of PECs across agencies that look very different depending on the type of agency. We've seen single agency PECs, we've seen regional PECs that have multiple agencies, particularly if there's volunteer rural component. We've seen many agencies, because nationally most agencies see less than 5 to 7% of the patients they care for are kids. So rarely is it necessarily a full-time position. So I would just put it out there, see what other people think. There's a few comments in the chat. And I think, Phyllis, your point about the coordinator is a big one, because a lot of times when there's a coordinator role, people assume it's a paid role versus a champion can be unpaid. So, yeah, sorry, I cut somebody off.
Sorry, Kathleen, I was just going to say that what you all are voting on this screen is without any specific recommendations for FTE. All it says is a designated PEC. So that's what you're voting on, is that reasonable for minimum criteria? I think, to Michael's point and others, if folks feel that there should be more meat to that, then that's a comment that could be made for the round 2. If this were to make it into round 2, that it should have maybe a higher level of expectation.
One of the ways we've looked at solving this in Wyoming is we're looking at, each agency, each hospital is available to have theirs, but we're going to look at putting in regional PECs. We're going to do that in cooperation with our healthcare coalitions. And each of the coalitions is going to find somebody within their coalition to support that as well. So that way, whether it's an agency PEC needing a roll up something or an agency that doesn't have one, being able to fall on a regional one. It's kind of one of the ways we're looking to solve this issue.
I think the key word here is designated, so that when you're assessing agencies with these criteria, they can say, yes, this is our designated PEC. This is the person or team of individuals that do our pediatric care coordination and serve as our champions. It can be somebody at our HCC serves in that role for our agency. I think that's specifically how we want to be able to dial that in. Thank you for that, Scott. I think that's an important point you illuminated.
So, Dr. Adelaide, this is Sam from Texas. So, as you know from the PEC Learning Collaborative, and even in our own state here in Texas, we find that a good portion of our EMS agencies actually have one or more individuals that are already fulfilling the roles and responsibilities of a PEC, but they don't necessarily have that terminology assigned to those individuals. And I think with that, where one of our biggest challenges, at least for us, is getting that education out to those agencies, letting them know, hey, you do have people that are already doing a good majority of these responsibilities. You're just not calling them a PEC, but that is essentially what they are. They are your PEC, they are your pediatric champion, or whatever term you want to assign to them.
Absolutely. I think that's a really great point, Sam. Thank you for that. And so the way every given state, as they draft their own specific criteria, can use the terminology, create a definition, resource the EIIC definitions of a PEC or kind of description of the PEC role that came out of that learning collaborative that's available on the EIIC website. I think we have a lot of resources to kind of help agencies understand what this means. When Cindy reports out that in Maryland, the champions met in October, and at level 1, it was a primary contact with participation with the state EMS at a minimum, but not additional pay. I think the issue, we're not asking whether the PECs are paid. That, that's not necessarily part of this. If that is a criteria that people feel would maybe be something they want, we can bring that back to the group for a reassessment later. Does anyone want that for Casey to kind of put a pin in for the group?
This is Cindy, and our group, and we only have 29 because of how the law is written, was very clear. They didn't want to be paid to do the role. They thought it was part of their job, whether they were volunteer or career as a professional. But what they want from us and what they want from the criteria is a commitment from their supervisors for protected time so that they can actually do it.
Got it.
Good afternoon. This is Miss Jackie from the Virgin Islands. And so I just wanted to share something on the PEC. For the last 2 weeks, I've been on a crusade between the territory. And so I sat with the hospital administrators and individuals from the NICU, the nursery, the emergency room. And one of the things that I did is I offered pediatric training to them. So for the last 2 weeks, we've been doing pairs, we've been doing PALs, we've been doing assessments. And in exchange, I use the opportunity to explain what EMSC is, what we do, because I didn't have any PEC in the St. Thomas district. So by going, explaining, giving the training, I turn out with 3 PECs. So I have 3 PECs to put in the CLEMS, and they're just happy that we're going to continue to come and assist them with the training and the skills. They were also impressed with the type of mannequins and equipment and the real feedback that they were giving. We work on IO scale, IV scales, just simple airway, the PAT assessment, primary assessment, and all of those things. And we were able to moulage and just make it really, really, really realistic. So we did 5 days in St. Thomas, and we had 29 participants in the St. Thomas St. John district, and we had 38 participants in the St. Croix district. So now the territory has 5 PECs. Thank you.
Wow. That's wonderful. I think that's really helpful to hear. A great way to kind of get the word out about what PECs do, both in hospitals and for EMS. Dwayne, you have that when you added that PEC requirement in 2020, it didn't have any resistance at all. Lower level services have, that have less resources and less contribution of the role. I think that one thing that we want to be mindful of in the criteria as a whole is, you know, we can be very aspirational about all the bells and whistles an agency may have that's perfect, but we really want to kind of make sure that what we're kind of setting up as that minimum criteria is something that, you know, we feel is really essential, and kind of voting forward with that in mind. So any other comments on this, or has everyone been able to submit a response to the poll? Okay, I think we may be ready to move on to the next one, if the group is okay with that.
Just getting a few last minute votes in, so please make sure you go ahead and cast those now.
Okay, I will move on to the disaster plans that include children. So there's a broad of reasons why this is part, and as you could see that there's a big gap between the current existing pre-hospital readiness recognition programs of the 9 that exist on this issue and what state partnership programs and others are being asked to kind of do. And there's probably a variety of reasons for that. One is that, you know, we have climate change and human-caused events that are increasing in frequency and severity across this country. We see that like every season, every day. We also know that children are disproportionately impacted by disasters through loss of life of caregivers and also the lack of facilities that are ready to care for children. One important thing is the most recent statistics out of the ASPR office is that really only about 27% of EMS agencies actually engage in a healthcare coalition, and that's in contrast to 85% of hospitals. And so again, a huge gap here, and so something that I think we need to be mindful of. And then finally, hospital data that is published by Kate shows that disaster programs are actually associated with a reduction in patient mortality. Now, we are extending this to the out-of-hospital environment, but we know that EMS provides care on this very critically important continuum. And there's certain elements of disaster preparedness isolated within the EMS agency that we feel like may be important to have in a readiness recognition program. So with that, we identified, I think, 3 or 4 things, and you want to bring up the next slide. Yeah. So first, does your EMS agency have a pre-hospital disaster triage algorithm that includes children? Now, this does not have to be the Jump Start, which is specifically pediatric, but if there is a algorithm that is used and the providers are trained on how kids would fit into that algorithm by the agency, that is, I think, the heart of what we're asking here. The next one is, does your agency have a mass transport policy or protocol that includes children? And then the third is, does your EMS agency participate in disaster drills that include children? And already there are definitely a few things popping up in the chat about this. So Mark, do you want to speak to what you put in the chat?
I can. I guess my overall concern is just that, you know, I love the idea of these considerations when we're building readiness programs. But if I go out tomorrow or next year and say, XYZ ambulance service, these are the standards for you to achieve readiness, the more criteria I put in front of them means the more they're going to back away from participating at all. And my worry is that these might be theoretically and potentially yet to be seen, but potentially evidence-based. They so lofty as a concept that they're going to drive any potential enthusiasm or energy from this, because people are going to look at this and say, well, I can't participate. I can't give you that much time. I don't have enough time to staff my ambulances, let alone develop these things. And I realize that there's got to be some criteria, but I'm just worried that we're putting so much in front of this that it'll look really good, but be unachievable.
I thank you for that information. I think that is when we talk about what are the key components of disaster readiness within the EMS agencies, the PPRP checklist and information in the technical report published the joint and the joint policy statement, you know, have a lot more in there. And these were, as we started, our thoughts of 3 basic things that were within the control of an EMS agency potentially. So, you know, again, that's what we're discussing here, and you know, some additional thoughts from the group. We all understand that when we create any set of criteria for recognition, it puts onus on an agency to do stuff that they may not already be doing, and that's tough, and that can stress agencies out for sure.
And I think one of the things just to keep in mind, and kind of goes along with what Mark was saying, again, Scott from Wyoming again, sorry. And we've seen this not just in EMSC, not just in HPP, you know, FEP, all the doors, is a lot of these programs are really centered along the populous areas, so along the coasts. And a lot of these projects leave out and don't think about the rural and frontier nature of a lot of us, you know, in the central United States. So just something to keep in mind is, as we build these, where are we building them for? Are we building them for those services that have the full-time staff, that have the full-time folks in place, or, you know, enough volunteers? Or are we building this for nationwide, for all thought processes and all different types of services? So just something to stick in our minds as we continue to grow and build is, what are we designing this for, and who are we designing it for?
Well,
Jackie
with that
here.
in, oh, go ahead, Jackie, go ahead. Thank you.
Jackie here from the Virgin Islands. One of the things when we move forward, we live in a hurricane, tsunami zone, and there are disaster plans, but the disaster plans don't cater to the children. And so one of the things that I've been doing, because we're so strategically located so far from the United States, and that we have to wait for days in terms of help being able to come in to us. And we only have 2 EMS systems. So when I move to them, this is how I move to them. I'm here to help you. I'm here to support you. And I'm really, really excited that I was able to expand my fan group, and many of the individuals in my fan groups are EMS providers, EMS educators. So we came up with our EMS agency last week, where we're going to help them to do continuing education hours. And I also serve as the state EMS director, and so one of our role is to inspect the ambulances in the territory. So we have a little different, unique situation, but we want to go out there and make sure, and I'm sure all of you guys are doing this, just partner with them, walk them through, help them through, and show them, you know, basically what needs to be done. You know, right now in the Virgin Islands, EMS was just moved from the Department of Health into the fire department in July, and last week the new director for the Virgin Islands Fire EMS, he succumbed to a cardiac arrest. And so tomorrow we're having, not tomorrow, but Saturday, we're having a big celebration, and we'll be having his funeral. So we're just here supporting the men and women who respond, because as you all know, it is not a job, it's a calling. Over.
Thank you, Jackie.
This is Carrie from New Mexico. I'm going to have to agree with my colleague from Wyoming that some of these, while I agree with them in principle and stuff like that, I had in my advisory committee meeting just yesterday down in one of our least populated parts of the state. And when we were talking about some of this criteria for recognition, you could see a definite, it was a palpable just deflation with some of these agencies that can barely keep the wheels turning on their rigs and stuff like that. So we're looking at ways to try to regionalize groups of agencies to put these plans together, but it really, for some of our frontier states, some of these mass transport policies and stuff like that are just going to be daunting for some of these smaller agencies. Thanks.
Sure. Yeah. It may, I mean, these are the three that we felt that we are put up for discussion. If you don't feel that, if you feel like it's too aspirational and not feasible, and also may not benefit anyone, you know, I mean, that's what is here to be discussed and voted on. Again, I think that, as Kate had mentioned at the beginning of this meeting, even if you choose to vote yes at this point, you later can be ranking these items based on feasibility, importance, and evidence, right? So, so think about it from those terms about, you know, being able to refine these and or use some of these basic things as a way to discuss kind of which parts or pieces are really the most important.
So this is Sam in Texas, and I guess for the states that don't have requirements of their EMS agencies to participate in at least the regional disaster plan, that, in my opinion, at a minimum, each EMS agency should at least have a disaster triage algorithm that includes children. Any EMS agency that pulls up on an MCI involving a school bus, do they not have a triage algorithm to determine level of injury and care for those kids, even in the most remote rural areas? That's just my 2 cents.
Yeah.
Yeah, and
I
Sam,
did want to, oh, go ahead, Scott, sorry.
Oh, no worries. I was going to say yes, and I think this is where there's a difference between a triage algorithm, which we all have, we're all, you know, all the EMS agencies are taught, versus the other two. I mean, most places, their mass transport plan, so we call the school district and get a bus. So, and I think that's not necessarily a policy, but a practice. And I think that's part of where we need to figure out is what needs to truly be policy versus what needs to be practice versus what needs to be local preference. And that's where it's hard to push some of the policy level thoughts down on somewhere that, you know, they have a very defined local practice. So I think that's more of kind of the thought process here, not that we can't triage them, but, you know, the other parts of that goes on. So we all know some of the worst words in, you know, emergency management is it'll never happen here. But as we know, until it happens, a lot of people never even want to think about it.
Right.
Sure.
And I agree that trauma triage is not the same as disaster triage, but with your smaller EMS agencies in a rural area, a school bus accident could be considered a disaster, you know, for them. It overwhelms their resources. And for many of them, they would have to activate the regional trauma plan to address that, or a school shooting for that matter.
Right. So I mean, I think my report or kind of response to Amy on that is that there is trauma destination triage, and that is different from pre-hospital disaster triage, where you're triaging patients as black, red, green, yellow. They're different schema, and they have probably overlapping roles in certain situations. So I was just making the distinction between the two.
This is Dwayne. I saw Mark's note, and I think someone else made the same statement, and I had already done it. This isn't an agency level piece, and I'm going to say over half of the agencies throughout the state, because it requires a lot more composition than most agencies have authority and responsibility over. This is a region or a statewide issue of determining destination and resources and the assignment of roles and stuff in a mass casualty. It may be part of protocol. It's mentioned in ours, but it's not the plan. It refers to the regional plan, and that region, you know, varies. It's not the EMS region, but it's a regional area. So I just think the question being asked at the agency level, I'm hearing that it's more effort than most agencies have the bandwidth in order to handle, let alone a role or responsibility to have it at their level of delivery for an MCI.
Perfect. That's helpful information. I think there's been a couple comments in there around, you know, whether the criteria should be something more along the lines of, do you participate in a regional disaster system? And one of the things I would just posit as we think about these criteria, any criteria for that matter, is if you were to go out and do a quote site visit with your agency, what would be things you would want to see as evidence of their, you know, quote disaster readiness, you know? And so I think if the group, I would want to close this discussion at this point, if possible, to move on to some of our other criteria. And, you know, we've taken a lot of this information, and this means being recorded. And so we may come back with a different set of items that for the group to reassess. Kate, does that seem like reasonable to do at this point?
Yes, for sure. Sorry.
Okay.
Thumbs up, but you probably couldn't see. Yes, please do.
And last
All right.
call, it looks like we're looking for 8 more votes. Last call for those folks.
Thank you for your comment, Cindy. Yeah. Are we ready to move on, Julie or Casey, whoever's controlling the slides? Okay. This is the established process to demonstrate the correct use of pediatric equipment, and specifically looking at the frequency of which agencies, sorry, I got distracted by the poll response, frequency of EMS agencies performing skills. Again, this is something that they get assessed on pretty regularly, and the most common examples are whether they assess their skills in a skill station or in simulation. Next slide. So when it comes down to correct use of pediatric equipment, the two thoughts on this would be, first, pre-hospital personnel can locate pediatric specific equipment. And the second is pre-hospital personnel can physically demonstrate correct use of pediatric specific equipment. They are two separate skill sets here. So and we know from simulation, other things, that sometimes knowing where your PEDS equipment is actually a core competency that some EMS agency providers struggle with a little bit.
That's a question regarding the first question. Locating a specific equipment for me, when I solicit my agencies around town, oh yeah, I know where it is. It's sitting on the shelf in the back in the station, which does nobody any good. So I get the concept of the question, but knowing where it is really does not help the situation of taking care of patients. So is there any room for us to revise that, or is that something we just need to vote yes or no?
Sure. No, I think that the point of this question was location in their pediatric bag or in their jump bag, the actual equipment, pediatric equipment that gets carried in the ambulance. Because even in simulation, we watch EMS providers struggle with knowing where the pediatric equipment is in their bag. The bag gets destroyed and things go flying. So that's kind of one element here. So if we were, more specific, pre-hospital personnel can locate pediatric specific equipment in the ambulance or in the jump bag. I don't know how we would want to revise the language to be more specific.
Okay, so this is assumed that it's in the rig or somewhere they could be, not sitting in a shelf in the storage.
Correct.
Back in the station.
In actual clinical practice, being in the field. Okay,
I would come across a few that it's sitting on the shelf in the storage unit, so I just want to make sure that's clear. Thank you.
And yeah, Jason, to your point, that's why they're two different questions.
This is Cindy, and I don't want to prolong this. I know we're running behind, but question 2, demonstrate at a drill, demonstrate in training, demonstrating in an EPC PALS class is a very different question than has every single provider been supervised within the last year or 2 years by someone else. I know it's in the performance measure, but that second part, I can retire 20 years from now and I won't be able to do it.
Mm-hmm.
Cindy, just a comment. I think it was written to be intentionally broad and up for interpretation. It's the general concept that this be integrated somehow or some way into criteria, and I don't think it was intended to be overly specific for agencies.
So, Jackie here again. One of the things that the EMS agency here did is within their QA/QI policy, they have that every quarter that the EMTs have to have a skill check. So that kind of made our job a little bit easier. And so this past EMS week, what we did was we did a skill check challenge, and they all came over, took their challenge, and we had some good goodies to give out for EMS week. And so we went over the Breslow bag and the Sega splint and all of the different things, and each individual actually participate in putting them on and measuring them and doing all the different things. So we're just finding different ways to adapt and to overcome as the program requires us to do. So I think it's a little easier for me because I'm in a smaller area and work within the Department of Health and partner with the pre-hospital disaster team, FEPS. And so maybe it makes it a little bit easy. But if you guys need help, just call on me.
So I think the feedback on these questions is really valuable. And I think we've done it, as Kate said, it's been written intentionally broad. It will be assessed per the way that the performance measure questions have been asked. Though that's going to continue to be assessed as a whole. How the states want to verify these or how the agencies respond to these questions is whatever way the state wants to draft that. So. Okay, has everyone voted? All right.
Last call, looking for 5 more votes.
All right. Next one is pediatric specific policies, procedures, and protocols. The ones that would be pediatric specific are shown there. And this gets back to the question about trauma triage versus pre-hospital disaster triage. So the use of trauma triage destination protocols with pediatrics in mind, the care of unaccompanied minors, refusals that involve children, and child maltreatment reporting. Many EMS agencies may already have this because it's mandated at the state level, but there are some states that have not necessarily recognized EMS providers as mandated reporters. So with that, we can go to the next slide. So these are 5 here for you guys to choose to vote on. The includes the first one is the trauma triage destination. The second one is regarding the care of unaccompanied minors. The third is regarding refusals that involve children. The fourth includes pediatrics in policies and procedures regarding child maltreatment. And then the fifth one is integrating elements of pediatric and family or patient and family centered care. Don't all speak at once. Dwayne asks if this is needed, if they're covered in EMS state protocols and statute. And Dwayne, I would, I think then if it is, it's an easy thing for the EMS agencies in your state. I'm not sure all states necessarily include this. And so, but I think that's a really great point.
I was just going to chime in that Colorado does not have statewide protocols. It has very little statewide coverage when it comes to EMS rules and regulations. And so, you know, while Colorado is a mandatory reporter state for all EMS providers, actually making sure that kids are covered in everything is really left to the determination of the EMS medical director and the agency and the regional trauma advisory council. So this measure does ring importance for, you know, states like Colorado because we don't have any uniformity in this. Now for states who do have this, it's going to be an easy check off, but this is why I personally think it's important because we don't have that universal coverage across the state for policies and protocols, and kids often get left out because they're not frequently seen or are kind of an afterthought.
either no one likes the criteria or it's a pretty not controversial thing. So I don't know if anyone has voted yet or not, Casey.
Looks like we're looking for 10 more votes.
Kathleen, can you clarify number 5? Having an element of patient and family-centered care in the PPP. To me, that sounds a little vague and sounds a little subjective. And I'm trying to think of an example in our protocol where you need to, if a patient with autism, you need to have parents in the ring. Something is that enough to get this mark checked, or is there a specific way to incorporate this recommendation?
I think, thank you for that. I think how individual states want to define this, I would leave it up to them, but there are a variety of recommendations out there for family-centered care in the out-of-hospital environment, specific things regarding cultural and competency care. So treating families according to their religious beliefs or cultural beliefs. Other examples include allowing parents to be present during resuscitations, etc. So it can look in a variety of different ways. Oftentimes there are EMS agencies may have local procedures or policies specific to some of these things. And so how an agency defines family-centered care for themselves, or how the state would want to kind of inquire about that, I think would be up to the state. I think the question here is, do we feel that having some element of family-centered care at the agency level, that it acknowledges it and thinks about it and addresses it in some way, is an important minimum criteria for overall pediatric preparedness, pediatric readiness.
Very clearly stated. Thank you.
Dr. Adelgaze, I'm asking this as a question, but I'm kind of making a statement. It's kind of follow up to what Nicolina just said. So, for example, with regards to child maltreatment and state being mandatory, or EMS providers being mandatory reporters by statute, will a statement in the program, not the agency's policies or procedures, but the actual program, that this is a requirement based on whatever the statute is, be sufficient that it meets the minimum because it's required regardless of whether the program requires it or not, and therefore they don't have to have that particular policy or procedure for child maltreatment because it's a requirement far above any program that we're going to implement, just in that hierarchy of responsibility in state statutes and codes.
No, thank you for that, Dwayne. I think that, again, we know that some of these elements are actually regulated, but for thinking through either, states that don't have this written into code or regulation, if you are in a state that does, that's an easy checkbox to just hit. Yep, done. If you're not, and it's something that the agency has to individually do, then there's decisions about how to kind of get that done.
And I just did a quick search, and it's everything I'm finding says that all states have mandatory reporting in place. So
all states have mandatory reporting in place. Not all states identify EMS professionals and clinicians as mandated reporters.
Okay, perfect.
In Colorado, it didn't happen. Yeah, Colorado didn't have EMS providers listed as mandated reporters till 2014.
Perfect. That's the part that I was missing. Thank you.
Can we move on to the next slide?
Go right ahead.
So pediatric equipment and supplies. The reason why we're including this as something to discuss today is that the availability of pediatric specific equipment is a key component of pediatric readiness. As we talked about before, even knowing where it's located is kind of maybe one thing that we want to know if agencies have a way to frequently monitor and check that. The other is that there are national guidelines for the minimum equipment for ground ambulances, and this element is frequently included in existing pediatric readiness programs. So with that, the next criteria are listed there. Does the agency utilize national consensus recommendations to guide availability of equipment and supplies to treat all ages? Does the agency have an established process for the regular verification of equipment and supplies? And then third, are all the recommended equipment and supplies readily available, i.e. not on a shelf back at the station? Mike, that's for you.
So just to clarify, number 3, it says all recommended equipment. Is that referring to the national consensus recommendations or the program's recommended equipment?
I would say that would be whatever, if you're utilizing national consensus recommendations, then it would be that recommended equipment. If the group doesn't feel that the national consensus recommendation is the right way to go, then it would potentially be a list of equipment that the state decides on. I think the other thing to consider, again, this is aligned with some of the points you made regarding policies, procedures at the state level. Certain states, counties, wherever EMS agencies get licensed in may have required equipment that they have to comply with. So, so most, so these are just, complex things to think about.
This is Debbie in Nebraska. Our state, I give them the list of the national consensus, but we don't have in policies or regulations what equipment they carry. It is totally up to their medical director.
Exactly. I think just your question in around, sorry, I'm just seeing it now, established process for the regular verification, that it's in stock and in working order. Are there any other comments or discussion points around this criteria?
Looks like Morgan has her hand raised. Go ahead, Morgan.
Oh, sorry. Go ahead, Morgan.
It's been a little bit since I've looked at the list. I know it's been trimmed down pretty heavily from what it used to be, but my only area of concern would be whether a state program would have trouble getting their recognition program kind of accepted by HRSA if there was something on the list that had to be required but was not in the agency's protocols. So I wouldn't want to require an agency to carry something they cannot use.
Thank you for that. I think that is helpful. The EIIC was a representative on the national consensus recommendations for equipment. So I don't think that if an agency is using that document as a basis for what equipment it carries, that HRSA would reject that as part of a state program. But I can't speak for HRSA. And we just had a disclosure slide at the start of this entire presentation that said we do not speak for HRSA. So just putting it out there.
So Morgan, just to speak to that national consensus document, the most recent one, the equipment listed is just a very basic list of equipment that I think probably the good majority of every EMS agency in the country carries, but that document gives the EMS agency medical director a lot of leeway into what medication, equipment, and supplies they carry in their department.
We're on criteria number 5. Are there any other comments? I saw Mark your comment and understand the potential challenges and issues that you outlined nicely. We're I think we have another 12 minutes for this meeting. Is that correct?
Yes.
Okay. We have a couple more criteria to get through, I believe. Oh,
Too fast.
All right. Can you go back a couple slides? Yeah. So this set of criteria is around, does the EMS agency have a quality improvement plan? And the rationale behind this is that right now there are some established EMS quality measures. There's the NEMSQL measures, and another example are the Florida FAIR measures. And then the NEMSIS Technical Assistance Center, the NEMSIS TAC, is creating a pediatric specific dashboard that will allow EMS agencies to track certain pediatric specific outcomes. So there are some tools available to EMS agencies for this. So the criteria number 6, next slide, is does your EMS agency have a QI plan that includes pediatric considerations? It's very broad, very general. We're not saying which considerations, pain or seizure or others. Any comments from the group about this before?
Aim for about 8 more votes.
Thank you, Jason. Understood. Challenges in Montana with a handful of agencies that may be able to do QI. We understand that that can be a problem for agencies. Are there any other additional people who'd like to vote before we move on to the last one? Okay, why don't we move on, Casey, to the last one? This is does your EMS agency have tools to reduce pediatric medication errors? And there's a lot of rationale behind this, including the fact that medication errors occur in about a third of pediatric EMS encounters, with a high frequency of both overdoses and underdoses. In fact, I just recently looked at a paper by Sriram Ramgopal and Chris Martin Gill that used the NEMSIS data set. And out of the a number of patients who receive midazolam, the large majority are underdosed, which is significant impacts. That being said, the other information that we do know is that EMS agencies may use volumetric dosing to kind of help reduce some cognitive errors, and weight estimation is an essential component to ensuring correct dosing of medication. And this was also a key area within the NPR, the Peds Ready Quality Collaborative was medication dosing error. So with that, we have a couple criteria here in our last one. Does your EMS agency use a weight estimation system? We don't specify whether it's a length-based tape or anything else, just use a weight estimation system. It could be age, it could be length, it could be looking at the parent's little card that they get from the doctor's visit. Does your EMS agency utilize a volumetric dosing system, yes or no? And does your EMS agency train on medication dosing for children? And I think your point, Jess, is a very good one. There are some BLS agencies, and here in Colorado, EMS, EMTs do have certain medications that they are able to give. So it is important to kind of think about that and put down as applicable based on your state scope of practice. I like that addition. Does everyone feel like they have enough? They're tired and done with voting? Casey, how are we looking?
Looking for 10 more. Are we ready to move on? Last call. I'm going to go ahead and close this poll. Great. Thank you.
Thank you all so much. I know that there's a lot of really valuable discussion here, which, because we're recording this meeting, we'll take all of the information in the chat and the recording to kind of and the vote responses and work on drafting that next round. I'll let Casey and Julie take it over from here.
You, Kathleen, and thank you everybody for the fantastic discussion and voting. And this is a great thing to watch happen. So in the beginning, Kate had gone over the emergency department timeline and the pre-hospital timeline. And now that we've kind of gone through each of those processes for round one and part of round two, we also want to show you how this is going to look in the next few months as we move forward in each of the Delphi process. And so today you can see in the November session that we kind of talked about what we had for round one in the ED criteria, and then we voted on round one for pre-hospital criteria. And then as we move, we're offline, and over the next month, we are going to send out round two of the pre-hospital criteria so that you can go in and vote or rank the criteria based on evidence, feasibility, and the importance. And that will be an online survey that Casey will send out on, I believe, November 27th. And so then when we come back, and then you're also going to be finishing during that same time the round two for the emergency department criteria, and that is open at this point. Some of you have already voted and submitted that survey. Both of those surveys will be open till December 15th, which at that point we'll come back on the 21st and review the results for both the ED and the pre-hospital criteria. And then that following month, again, we'll re-rank, we'll send out another online survey, and then in January, we'll come back. And if we need to do more rounds, we'll just continue this process. So we'll see what happens in January. So here's everything together where we'll be. So next steps, again, we're going to complete round two of the criteria survey by December 15th, and that survey is out at this point. We'll be sending round two of the pre-hospital criteria on November 27th, and that will be due by the December 15th. There was a sign-up survey so that once we complete this Delphi process for the criteria, we really want to start hearing more from you as your program evolves. And we want to start to learn from each other and where are our programs at this point. So that survey is out. When you get the slides, the copy of the slides here, there's a link so that you can also go in there and complete that survey. Start working on your action plans that we talked about at the all grantee meeting, the kickoff meeting for this. And our next session will be on December 21st. And I hope to see you then. And thank you again for all your participation today. We really appreciate it.
Thank you.
Kathleen, any other things you want to add?
I'm just very grateful for people taking the time to be here and have such a good discussion about everything.
Thank you, everyone. Happy Thanksgiving.
Thank you for having me. Have a great day.